Hello, everyone. Welcome to a new episode of the Dissenter. I'm your host, as always, Ricardo Lopes, and today I'm joined by Dr. Charlotte Blease. She is an interdisciplinary health researcher at the Department of Women's and Children's Health at Uppsala University in Sweden, and also the Digital Psychiatry Division at the Beth Israel Deaconess Medical Center at the Harvard Medical School. And today we're going to talk about her book, The Nocebo Effect, When Words Make You Sick. So Charlotte, welcome to the show. It's a huge pleasure to everyone.
Ricardo, it's fantastic to be here at last. Thanks for having me.
Great. So we're going to talk about the nocebo effect, but just before that, I would like to ask you a little bit about the placebo effect. So what is it?
The placebo effect is the better known of these two effects, and it is the response that happens as a result of patients expecting to feel better. So as a result of expecting to feel better, they actually do experience positive health benefits. And it's considered to be particularly relevant to experiences of pain, depression, anxiety, fatigue, and so on. And there's actually quite a body of research now. There's quite a mature body of research investigating the placebo effect. But it's still quite a young science, I will say. So as an organized field of research, while the so-called placebo effect's been known for quite a while, as an organized scientific field, we're talking about 20 to 30 years old.
And what is the medical relevance of placebos? I mean, why should we care about them from a medical standpoint?
That's a great question. There's actually sort of two ways to answer this question. So the first is that placebos are used as tools, methodological tools in clinical trials, and to that extent, they're really a measuring instrument. So that's the first particular usage, because there's lots of noise in clinical trials. Patients, you got to screen out for that noise. So if you want to evaluate a particular treatment and to see whether it's effective for a condition, you need a placebo, which is essentially should mimic everything about the treatment under scrutiny, except for the particular ingredients, if you will, that you think are going to make the difference. You don't need to have a mechanistic story about why they make a difference. You just have to isolate them the best as you can through the design of the placebo. So placebos are relevant in that sense, and it's quite seductive in a clinical trial scenario. And a lot of people think of placebos this way, including researchers, but they tend to say placebos are sugar pills, they're saline solutions. That's really not quite accurate, because a placebo, as I say, should be a sort of a measuring tool. So it should copy, in a sense, what it is you're trying to measure as far as possible. So it's like a moving category of things. It's a control. So that's one sense in which we can think of the relevance of placebos. The second sense is in a more clinical setting. And here we're thinking more about the vernacular in which people use the term placebo. And there's almost a kind of family resemblance situation going on descriptively about how physicians or patients think about placebos. But in that scenario, we're thinking about a treatment that might be offered to a patient, perhaps at a primary care visit, where the doctor doesn't think it's going to be effective, but they think they're offering them a placebo, but they just want to save face, offer a demanding patient something. They're not sure if it'll work. So if there can be many reasons, it might actually work, or they might actually want to elicit placebo effects. So they give them something that they think the patient will think will work. And so there's that separate area of placebos in clinical practice, which means something slightly different. I think in the field there's a tendency to talk across purposes a little bit. So I welcome that question. There's definitely a need for differentiation here.
And what is then the nocebo effect?
The nocebo effect, so the lesser known, to say, of these effects, is sort of characterized as the evil twin of the placebo effect. And it is what happens when you have negative expectations about a treatment or intervention, as a result of which you start to experience genuine negative effects. Much less research into this phenomenon, but quite interesting studies. Maybe we'll get into them a little later, but yeah, fascinating effect.
So, and this is also interesting because you come at things from two different standpoints, both from a philosophy standpoint and also from a medical standpoint. So, as a philosopher, particularly, how do you approach the nocebo effect?
Good question. So basically, I mean, when I think about philosophy, so my PhD was in philosophy, and I've sort of increasingly veered into quite an interdisciplinary health research. But I kind of go back to Wilfrid Sellars' description of philosophy, which is seeing how things in the broadest sense of the term hang together in the broadest possible sense of the term. And philosophers in general can approach things like the nocebo effects, or the ultimate mind-body effect, in a few different ways. My particular approach to these issues has been epistemological in the sense, in almost the most rudimentary sense of doing philosophy, which is to say, what is it? You can't measure what you first haven't defined. So how do we define these terms? And that's sort of become the lowest hanging fruit in placebo studies, if you will, which includes the nocebo effect. How are we defining these terms? Are we talking across purposes sometimes? So let's get clear about what those terms are and then how we could possibly investigate them. So related to that, I've also been interested in the replication crisis. So is it philosophical? It's evidence-based practice in a sense, but turning the question in on the field, are we being robust enough in our methodologies? Are we canonizing findings a little bit too early? We need to show due diligence. So again, it's the philosopher taking a step back and somewhat finger wagging. It's not always appreciated, but so that's one perspective. And another area of philosophy is of course ethics, clinical ethics, and thinking what are the implications of these effects. So the nocebo effect is a fascinating, almost sort of disruptive force in healthcare, because you want to ultimately you want to tell patients about the potential risks of treatments, possible side effects. How do you do that in a way that is honest and open without causing said effects and causing potential harm or secondary harms to patients? So that's another area that I've been interested in.
Mm-hmm. So later in our conversation, we're going to talk about the importance of distinguishing between real side effects of treatments, medication, and so on, and nocebo effects and how we can do it. But at this point, let me ask you, is there a risk of over-identifying the nocebo effect as the cause behind very diverse phenomena?
Yeah, absolutely. And we tend to see this particularly, as I say, as Thomas Kuhn talked about, the emergence of paradigms in research, and it's hard not to go back to that, kind of appreciate that kind of thinking when you look at the emergence of research into the nocebo effect. So there is a tendency, I think, to ascribe certain phenomena to nocebo effects. We're not talking about over-treatment. We're not talking, and some people have suggested that might be the case, and the nasty side effects of over-treating patients. It's not any kind of side effect. We're talking about a very specific kind of effect, negative effect that results from expectations. So yeah, absolutely, we've got to be vigilant, I think, about that. And I think when there is a tendency, particularly when we're thinking about something as negative as this as well, maybe to to get even more freaked out and to start overascribing but we really have to be careful in this case, for sure. If everything's the nocebo effect, nothing's the nocebo effect.
Yeah. And when it comes to the harms that come from overdiagnosis and overtreatment, should we treat them as nocebo effects, or are they more the result of side effects of drugs and unnecessary treatment?
I think it can be a whole amalgam of different things. So it could be the over-treatment, over-medicalization, lower thresholds for diagnostic categories, for example, in mental health conditions. These things could prompt nocebo effects. But again, we've got to be very careful about saying what it is we think might might elicit those kinds of effects, and then as a result of that, try to find some ingenious way of experimentally getting at that or empirically getting at that. So yeah, that's a tricky question, but yeah.
Mm-hmm. So, and do we have a good understanding of how nocebo effects are produced psychologically? I mean, what are the psychological mechanisms that play a role in them?
Another great question. I guess I would go back to, we don't really have a good, put my head above the parapet, we don't really have a good descriptive psychological depiction of these effects. And I think the same is actually fair to say in the placebo effect as well. If you go back to David Marr, the cognitive scientist, who thought about different levels of analysis, different questions you can ask in a particular field. You can ask the question of what it is. What is the phenomenon that needs to be described? Now, I think what we have a tendency to do when it comes to the psychology of nocebo effects and placebo effects is we have isolated what it is. It's an expectancy response in some sense. But when we drop, so the second question is that Marr identified was, not just the what, but how does this work? What's the mechanistic level to explain this phenomenon? And I think we have a tendency, in general, in psychology, to embark on a kind of circular reasoning and just to say, for the mechanistic reason, we're going to re-describe the thing that needs to be better understood, and that is to say, it's expectancies that are, but that doesn't really offer us an edifying explanation. So there seems to be this gap in what are the mechanisms, what's the sort of the algorithmic level of what's doing the work, the processing underneath. And then, of course, there's the issue of the where, the sort of instantiation. And there we do have some interesting studies in the nocebo effect on engaging cortisol or CCK is another hormone involved in anxiety responses. So in general, we don't have a fantastic story yet to tell about the mechanisms. And then at the other side of it, you can add the fourth question of why does the nocebo effect exist? So the ultimate explanations. And there we could ask questions about, is it a evolutionary adaptation, a byproduct of an adaptation? Probably there's something very interesting to say there too. In general, it's probably a readiness, an anticipatory response, better to better to anticipate negative events in your environment and be ready with a physiological response to them, and to err on the side of false positives than false negatives. So I think it's not too much of a stretch to tell a story there about why those why nocebo effects arise, and then the issue is, are we eliciting them in modern environments in ways that are not appropriate, that are mismatched in the very places that people want to get help, hospitals, clinics, and we're making people feel more anxious. So yeah.
So there is this common idea that if nocebo effects are caused by negative expectations, then they are merely all in the head. Does it make sense to think about them this way?
So a good question. And we see pushback, as particularly from patients when we talk about these kinds of phenomena, that it's a sort of degradation or discrediting. I think two ways to think about that question. Is it all in the head? First is quite literally, and we can say scientifically, is it all in the head? Well, it's a nervous system response. So the nervous system extends throughout the whole body, so it's not quite all in the head. But and related to that, we could say, look, if this is a response, some capacity, evolved capacity, that behavioral response, a suite of behaviors and cognitions that are as a result of observing something in the environment, you have to have the cues in the environment to elicit it. So it's not quite all, again, all in the head either from that respect. But the more figurative, I suppose, common parlance, thinking about, is it all in the head? I would be really wary about, again, saying that that we are diminishing certain responses in that way. And we've got to be careful too, because medicine has a history of gaslighting patients when it comes to conditions that are medically unexplained. Conditions like ME, stroke, so-called chronic fatigue syndrome, where patients were in fact told, we can't find the reasons for this, we can't see any causes for this condition, we can't understand it. To some extent, it wasn't in the doctor's head or the medical community's head what was wrong, so ergo the explanation is, well, it must all be in the patient's head, that they're making this up, or this isn't a real condition. So I try to stay away from the sort of all in the head. It's understandable to an extent, but it's a very loaded description, and we would not want to be saying many medical conditions are the result of nocebo effects. These are short-lived effects. They're probably not that severe, but they can have repercussions for healthcare. But I wouldn't want to be ascribing lots of unknown medical conditions to this.
Right. So this is something that I think is very important for us to try to understand. How is the nocebo effect produced in a clinical context? I mean, how is it that doctors and other clinicians unintentionally harm patients through it?
Yeah, again, good question. So, and probably the best way to answer this is by example. So it could be through the power of suggestion, through what's communicated to the patient, including about side effects, the manner in which it is communicated, but also to some extent, we might say that the performance of medicine. So a couple of interesting illustrative cases. Fabrizio Benedetti, who's a researcher in placebo studies from Turin, did a very interesting, what was called an open hidden style study. This was published in about 2003. But basically in this study, he had post-operative pain patients, and I hasten to add, this study probably wouldn't get ethical approval today, but he randomly allocated them to two conditions. One was the truthful, the open condition, where the patients were told that their intravenous pain medication had been disrupted, and it had been disrupted. And then the other condition, they were not informed that the intravenous morphine had been disrupted, even though it had been. And what he found was those who were informed, honestly informed about what had happened, were much more likely to request pain medication, needed higher dosages of it. Small trial, but that sort of offers a window to the potential, knowing that something has happened, you have a negative expectation and you start to feel much worse as a result. There's been other studies which are more suggestive. For example, one which is another sort of almost canonized study in the field, but done by an anaesthetist, actually at Beth Israel Deaconess Medical Center, where he randomly allocated patients he was giving them a local anesthetic, and he said, I'm going to give you the anesthetic. It's going to feel like a bee sting. And patients actually reported much higher levels of pain when they were told, I'm going to give you an anesthetic and it's going to make you feel better. So it's going to reduce the pain or help you manage the situation. So there have been studies like that which are more suggestive, and what you do find is patients do report higher levels of pain and so on when they're in the nocebo effect condition. I don't want to sort of prolong it, but another interesting study I think worth listeners might be interested in. It was carried out by Lauren Howe, who is at Alia Crumb's, or who was at Alia Crumb's lab in Stamford, which is a lab that's conducted quite a lot of interesting placebo research. And what they did in this study was they induced an allergic response through a histamine, healthy, normal people, and they induced this allergic response, which created a wheal, which is another name for the sort of itchy rash, the red rash that you get in your skin when you have an allergy or it's irritated. And what they did was they offered people basically a placebo cream. So there's no active ingredient in this cream. I'm veering into some of the language that I say you shouldn't use. But anyway, it was a cream that doesn't really work. But the manner in which people were offered the cream, so the provider's delivery, was what was experimentally under investigation in this. And they basically, to cut a long story short, found that practitioners who delivered the treatment with what looked like cues of high level of competence, so they were very confident, knowledgeable, and so on, and high levels of empathy, those patients experienced placebo effects, a reduction in the size, measurable reduction in the size of the response, the allergy response, and those who were in the low competence, low empathy delivery allocation actually didn't experience any diminishment in the size of the wheal, the rash. So how do we interpret that? And I say this is a short study, needed replication, but could that have been that there was this sort of nocebo effect response going on that was mediated by a perception, this person isn't competent, they're not going to help me, they're not empathetic, they don't look like they're trying to help me, and that's what might have influenced this kind of anticipatory response. So fascinating kinds of studies that begin to inch closer to what might be going on here and how to elicit these responses or not elicit them.
Mm-hmm. So can the nocebo effect be produced in different ways in a clinical context?
It could be. So again, it could be through the behavior of the providers who say, it might even be, I'm not advocating sort of feng shui in the clinic, but it could be if you're in a clinic that looks disorderly, that might signal some sort of level of incompetence, say, or it doesn't look as clean as it could be, for example. There could be certain cues in the environment beyond the practitioner that lead the patient to have a negative anticipatory response. But it could also be things that the provider is doing too. Do they instill confidence or not? Do they look empathetic towards you or not? Or are they being cold and disinterested and too busy? And aside from all of that, what is it they're telling you? What's the power of suggestion here in terms of the information that they're giving you? And if it's negative information as well, that may lead to these sort of negative expectancies.
And how can we distinguish real side effects of treatments from nocebo effects? And is it important to establish this distinction?
I think it's important to establish the distinction. I think it's quite difficult to do, but it's certainly possible to do. I think when we again go back to with nocebo effects, these are likely to be short-lived effects. They're not going to be as severe effects as some treatment side effects are going to be. They're not unlikely to be dose responsive. So a real treatment may, the higher the dosage, maybe the higher the level of the toxicity, the negative, the side effects are going to be. So, but again, we need more studies to investigate whether that's in fact the case for the nocebo effect. It's certainly possible to do. It's challenging. If we go back to the clinical trials, where which are a great venue for beginning to identify some of these interesting effects, but they're not a great way to isolate the nocebo effect, for example, because as I've said, there's a lot of noise in a clinical trial. If you give people, if they're allocated to the placebo arm in a clinical trial, and then they experience negative effects as a result, that could be owed to natural history. Some people are going to feel worse anyway. It could be responder biases. You're told that there's a potential for side effects and you actually just report them, but you don't experience them. It could be attribution of symptoms you already feel. You had one too many glasses of wine the night before, you didn't sleep well, whatever, and you're misattributing some of those low-grade symptoms that any of us may feel at any time to side effects or whatever, and then as a result, it would be a conflation to say those are nocebo effects. So it requires a lot of ingenuity to try to isolate exactly these specific effects, but the kinds of experiments I mentioned are a good starting point for thinking about how we do that.
So I probably should have asked you this question earlier, but why should we care about nocebo effects? What kinds of consequences can they have?
Well, the sort of the first issue is that they can make people feel worse, and we don't want, particularly in the medical setting, we don't want people to feel worse. And if people are already experiencing, say they've got a chronic illness, you're offering them medications, it could be a tipping point scenario where, even if some of these the nocebo effect is sort of time limited, it's not as aggravating as some other side effects may be. We don't want to compound that, and we don't want people to really to experience worse, to feel worse as a result. So there's that issue of just the negative effects in themselves. But there's also the issue of people dropping out of care or becoming anxious about taking medications. And so either through word of mouth experiencing these kinds of side effects, there are health repercussions. I'll give an example. 70% of the world's population had a COVID vaccine. Mm-hmm. But many people, we don't actually have the exact figures, but many people didn't get a second vaccine. Why is that? One of the leading reasons was side effects. And we can perhaps get into the literature and nocebo effects, nocebo responses to the COVID vaccine. But that in itself, there's the public health consequences in the sense of potential here for nocebo effect as the cause of health behaviors can be quite serious. So from a small thing, big things can emerge. Look at, if you consider lack of, very paternalistic term, but lack of adherence to medications, bad patients not taking their medications. But a lot of the reasons patients do that is side effects. So, and in the US alone, it's estimated about 100,000 deaths every year because people don't take their medications as they've been prescribed. So it's a serious issue. It's a costly issue as well. I think it's figures of $100 billion in the US every year because of failures, the consequences of failures to take medication. So it can be a costly issue, both literally and figuratively, the patient's health. So it's the downstream consequences, I think, that might be some of the most severe issues here.
But can nocebo effects do actual clinical harm to people more than just producing more side effects and leading people to quit their treatments?
I think it's a very, very good question. What are the extent of it? Because we don't want to exaggerate the effect size here. I think that would be a big mistake. I think it's I don't really want to answer the question because I don't know. But I would suspect that, as I've said, these are limited effects in many ways. It depends how one wants to interpret harm, I suppose, to the extent of the harm. But I think it's open to empirical questioning. So, for example, if you the study that Fabrizio Benedetti carried out, if patients really need higher levels of pain medications as a result of behaviors within the clinic, if you're experiencing a much higher threshold of pain, that's not a good thing. Now, the extent to which the pain can be dialed back through behaviors that could reduce those sort of nocebo effects is an open question. We might even say, like, what is the actual dosage of morphine that you over and above you've got to get? What is the equivalency? But there is. I would be cautious here too. It's a good question because, in general, as I've said before, we've got to pay attention to, especially when a field is hot. When you've got this idea of a mind-body problem, the placebo effect, and nocebo effect. We're doing an interview on it. I've done different kind of media things on the placebo effect. It's a hot field, and there's always a tendency to exaggerate effect size unwittingly sometimes, but scientists do it too because you can court a bit of media attention, and there is this publication bias too. Of course, you find positive findings, they're more likely to be published, canonized, cited widely, fewer replications. So we should be, I say, do your due diligence and not exaggerate what possibly is going on here. So are they harmful? They're not pleasant. How do we want to decide what's harmful? It's an open question.
Mm-hmm. And can words themselves produce harm? I mean, if, for example, a procedure is expected to produce some pain and doctors mention it beforehand, can it cause even more pain than it was supposed to?
It could do. So again, we could take a look at that open hidden paradigm, the study by Fabrizio Benedetti, where what was simply disclosed or not communicated did make a difference to reported harm and for the need for medication. And we've got other studies that suggest similar things, that what is communicated is what makes the difference to patients. I could give another example of, again, this was from Alia Crum's lab, where they did a fascinating study on, and this study actually lasted for around 6 months. So patients with peanut allergies, and the treatment for that is to sort of give a dosage of the peanut in order to get the antibodies levels up. And in both groups, they actually communicated that you will feel side effects of this treatment intervention, there's going to be some discomfort, scratchiness in your throat. And they advised in both, in the randomized control trial, both groups were told the same information, but in one group, they were told that's a signal the treatment's working, you know, stick with it. So it was positively framed. And in fact, that made a difference to sticking with the treatment regime, to the extent, I think it was only 4% of people dropped out whenever they were given the positive framing, versus only 20% who weren't told, you know, this is a positive signal, reframing, reinterpreting the negative side effects. And in fact, at the end of the 6 months, patients in the positive mindset, the positive framed information, had higher levels of antibodies. So the treatment actually did work. So there we're getting at how you can manage expectations in a way that's positive for patients, that actually can mean that they adhere to treatments, they stick with it, they're less anxious and fearful, and you can help overcome what potentially the side effects possibly be via dialing back the nocebo effects, or negative expectancies about how to think about these negative effects. So there are going to be many ways, I think, in which providers, especially if they had the time to do it, but could be better managing patients' expectations, leading to more desirable health outcomes.
Mm-hmm. Are healthcare professionals aware of the nocebo effect? Do they underestimate it? I mean, what do we know about that?
We don't know a great deal about it, but when we wrote the book, we suspect that just through almost anecdata as well, healthcare professionals don't know as much about the nocebo effect. It's been this overshadowed phenomenon, which is interesting in itself, but we suspected that there's just not that much awareness about it. Interesting. So when I speak to people about it, they'll say, "Oh, I've never heard of that," but they've heard of the placebo effect. So I think more education, more literacy around that could only be a good thing, and it'd be beneficial for patients to know as well, because they can begin to find ways to manage their own expectations. Or my own case, I don't like to read the side effects of medications. I think, well, knowledge isn't always power, you know, so in that scenario, I don't really want to know.
Yeah. So let me ask you two or three questions about psychotherapy specifically. So, and please correct me if I say something wrong here, but it seems that it doesn't matter much what type of psychotherapy is used. They all tend to work more or less equally well. If this is the case, and if different kinds of psychotherapy are based on different theoretical approaches to human psychology and apply sort of different methodologies, does it mean that we might be dealing with placebo effects here? I mean, could it be that psychotherapy is mostly placebo?
It's a really big question. Yeah, so there is this debate in the evidence base in psychotherapy, how to interpret the findings. There's some controversy over it too, I will say. But so, for example, Bruce Wampold is a researcher in this field who advocates the perspective. He says that it doesn't really matter what treatment you give. It could be a sort of cognitive behavioral therapy. It could be more of a sort of Rogerian humanistic therapy. It could be a psychodynamic therapy, sort of embarking these archival digs into your personal history and all your childhood and all the rest. It doesn't really matter what you do, that they all tend to have, they're much of a muchness. And sometimes this is called the dodo bird hypothesis. So from Lewis Carroll's book, where I think it was a dodo bird had said, you know, there was a race and everyone has won, all must have prizes. So how do we explain then the effectiveness? Because psychotherapy is quite effective. It's very effective for many patients, though not all. But what is going on, and then as sort of as a result of that, is this idea that of the common factors hypothesis. So there must be factors that are common across all versions of therapy that are what make the difference here. And so it's getting into what could those core factors be, and they're thought to be things like the therapist's effect. So it could be high levels of empathy, could be signals of competence and so on too. It could be that the patient has higher expectations. They find the theory behind it plausible, something that they can get on board with. So is there sort of a core set of factors there that may be making the difference? And then some people say, look, all of those factors are really related to inducing placebo effects, and that therefore it maybe is just a placebo. I think it gets murky here because I don't really want to say that it would be a placebo, but I don't also think so. The idea is it all just a placebo or placebo effect? And researchers like Jens Gab, as a researcher at the University of Basel, has sort of notably advocated that might be what all that psychotherapy is, and therefore we should be communicating to patients what actually is going on here. So I would say that I don't believe that that's necessarily everything. I don't think that psychotherapy is just a placebo effect. I think there's possibly other things that are going on in a psychotherapy encounter that could be beneficial to patients. I don't want to digress too much, but it's a couple of thoughts on this. Say depression is an adaptive response, for example, but in some scenarios, in modern environments, we're getting more and more depressed. What might be a way to, if you think about theories as to why people get depressed? Couple of theories. One is it's an analytical, a rumination hypothesis. So when you're depressed, you're more likely to think deeply about difficult social problems, and so it's a way of socially withdrawing, thinking more about them. Is it possible that in some psychotherapy contexts that the therapist actually facilitating you working through those problems, and that's what's beneficial on the top of the fact that you're getting this boost of possibly placebo effects? Possibly that's what's going on. It could be that additionally that the therapist is a role model, for example, of how to behave differently. And of course, therapists say that's exactly not what they're doing. They would never tell their client how to improve their behavior. Possibly that there is some kind of role modeling happening. So I think there are many it's underdetermined what exactly is going on in psychotherapy, but certainly we could say it's a forum whereby people could be induced to have a more positive expectancy about, am I going to feel better as a result of this process or not? And there's also it's also an arena where suggestibility, people particularly in a vulnerable state, may be induced if they're already feeling skeptical, depressed, whatever, anxious, could be made to feel worse. It might not always be beneficial to ruminate over problems, particularly if there's not much of a solution, or the therapist isn't offering suggestions of what look like plausible solutions. You could feel worse. And I sort of would go back to the late Scott Lilienfeld, who very iconoclastic figure very necessary figure in psychology, who was one of the first really to say that he estimated around 10% of patients felt worse as a result of psychotherapy. We don't talk about that enough, I think, because we tend to think when people are undergoing a treatment, a talking cure, so to speak, that there's not really any potential for harm, but in fact that there could be through a variety of means, one of which might be nocebo effects. You just don't feel, you feel worse.
So psychotherapy can harm, it can produce nocebo effects as well.
I think it's certainly think that's a very real possibility. So if we go back to the study on the Lauren Howe's study, for example, which looked at perceptions of competence and empathy. Now, if those influence the size of placebo effects, and potentially, and we don't have enough research on this, but say they also influence nocebo effects. If you're sitting with a psychotherapist and you don't think that they're particularly competent, or that they're not being as empathetic to your needs as they could be, that might influence you to have negative expectations about not only your current health, but about this provider's not going to be able to help me. So you either drop out of care, you think, and everything feels worse, and you think, well, nobody can help me now, or you start to feel considerably worse about your situation. So I would suggest that certainly it's plausible that psychotherapy could lead to negative effects for patients.
What about the use of labels and diagnoses in psychotherapy and even the medical system more generally? Can those produce nocebo effects as well?
Yeah, it's a really interesting question. And I think we sort of this secular trend of sort of lower thresholds for mental health conditions and diagnostic classifications. And without, again, we don't want to get into the sphere of saying, but I think that can be a good case to be made that in the modern world, more and more people actually are more depressed, they're more anxious and so on too. But certainly the over-medicalization of many everyday experiences, some of which may not be in the realm of medically significant, but are just, problems with living. If there's a tendency to over-medicalize those, and to tell people there's something wrong with you, as opposed to, I see most people feel lousy sometimes, or whatever, this is part of life. There could be a risk that you're inducing people to have a perfectionistic, idealistic perspective of what life ought to be like, and that as a result they have a really negative set of expectancies that in fact induce nocebo effects that could lead people to feeling just generally anxious and more depressed, more worried about their life. So I think that there is a real risk of that. Certainly do. Yeah.
So going back to the COVID vaccine for a minute, because you've already mentioned it briefly earlier in our conversation. So now and then we hear claims from people about supposed COVID vaccine side effects. How do we go about distinguishing real side effects of the vaccines from nocebo effects?
Yeah, so the really interesting literature came out of the clinical trial data for the COVID-19, the COVID vaccine. So various researchers looked at the data, and they found that people who were allocated to the saline vaccine, the fake vaccine, also reported side effects. And depending on the meta-analysis that you looked at, a couple of them were published. One attributed as much as 2/3 of the vaccine side effects to nocebo, and they used the phrase nocebo phenomenon. Another one said 3/4 of the side effects were. Why did they say that? Because again, the people who were in the control, who got the placebo vaccine, reported side effects too. So it seemed like which is really interesting, because it's possible that as a result of a few things going on here, and this is where it's almost sort of the clinical trials are not an amazingly good place to isolate nocebo effect nor placebo effect, because there's so much noise in them. But it could have been that because there's an amalgam of things. It could have been responder biases. That is, you're told that there's certain side effects, and then you mimic them, you know, unintentionally, sort of people pleasing response to researchers. It could have been again, misattribution of certain low-level, low-grade symptoms that one already feels. Could be natural history, but it also could have been genuinely, in that case, people were told about the side effects, and as a result, they did start to feel worse. Or it could have been, well, that's possibly what was going on. In which case, we would say whatever was happening in the group who received the actual vaccine over and above, that might have been the genuine side effects associated with the vaccine, which were not that many proportionately compared to when you received a placebo. So yeah, so isolating those effects and this differentiating them from genuine nocebo effects is really, really tricky from the noise of, if you like, more broadly, you could talk about the nocebo response. Tricky situation to isolate those. I'm not sure if that quite answers the question, but yeah.
Yeah. So let me
question. Yeah.
So let me ask you a different kind of question now. When it comes to media reports, because sometimes we get negative media reports of certain medicines, can they produce nocebo effects as well? And I mean, in this particular case, since we're focusing a little bit here on the COVID vaccine, is it that, for example, the media communicating about potential side effects of the vaccine might have contributed to producing nocebo effects in people? And I mean, I would imagine that this is a sort of delicate question or delicate thing to explore, because, of course, from the perspective of medical deontology, potential side effects have to be communicated to patients, but it can be done by doctors, not necessarily by the media. So, I mean, what do you think about this?
So, yes, it's again, I mean, the media could play a role here. And I think it's really challenging to answer this question because it does require, I mean, so the media, we know that people are more attentive to negative information. You know, and again, there's sort of an evolutionary, evolution has sort of bequeathed a kind of an heirloom in that respect, in that we tend to pay attention. It's more adaptive in our history to have paid attention to negative information, to be more ready to respond. But in that, and we know the media, you know, if it bleeds, it leads, you know, so there's over-reporting of negative information. Now, does that potentially induce nocebo effects? I don't think we know, but it could certainly be part of it. There could be a contributory factor there for communicating at scale what a doctor might be communicating about a vaccine. So I see no reason to think that it couldn't possibly be contributing to nocebo effects if you have what you think is medical information, and that influences in the moment when you're receiving the medication, you're aware, or what you think might be the case. I think it's certainly a possibility. How you measure these things, sort of as a cognitive anthropologist, and you work out what is making the difference, what kind of exposure people, gets really, really tricky to do that. But I think that sort of on the face of it, there's no reason to think that there couldn't be a contributory force, if you will, in terms of media communicating information at scale, as I've said, to the public.
Mm-hmm. And how can COVID-19 vaccines nocebo effects be reduced?
So they could be reduced. Well, I'll give you an example actually of my own case. When I went to get the COVID vaccine, the first vaccine, the nurse said to me, "You're going to feel a bit of a, just going to feel a bit of a pinch here in your skin, but 12 hours from now, she was highly specific about it, and I wish she hadn't been. She said 12 hours from now, you might start to feel pains, shivers, headaches. Just take a couple of Tylenol. This was in the States, so in other words, take paracetamol. And sure enough, like 12 hours later, I looked at my watch, I really did, and did start to feel terrible. And part of me wondered, being familiar with nocebo effects, I thought, shit, is this just a nocebo effect? Or in fact, am I having a really negative reaction? I mean, are these genuine side effects? I'm just second guessing myself, what's really going on? And I really didn't feel at all well. So was there a kind of amplification through my negative expectancies as a result of the information she gave me? Possibly. So I think what I would say in that case is, how could that nurse have handled it a little bit better? Well, she could have framed the information a bit more positively, instead of being so definitive. 12 hours from now, which made her look highly competent and made me, it was just so specific. She could have said something like, most people don't experience side effects. If you do, you can manage it with Tylenol, or so positively framing the information while preserving the truthfulness is one route forward. And that might be a way to manage, could have been a way to manage nocebo effects in relation to the extent that they arose in relation to the COVID vaccination, indeed any kind of medical treatment. So thinking here about Gert Gigeren's or Daniel Kahneman's sort of decision theory, framing information in a specific way, instead of saying 30% of people might feel side effects, you just say 7 in 10 people don't experience side effects. You're likely to be one of them. Blah blah, and that, so you're managing the expectations in a more positive valence.
Mm-hmm. So, I mean, this is sort of also related to COVID because it was a public health issue. So, how do nocebo effects manifest in public health, and how relevant are they in that specific context?
Again, it's unclear. So there have been stories that relate to things like wind turbines causing outbreaks of illness, but are these just as a result of mass hysteria, which is a sort of a way of saying, it's all in people's heads, and it potentially then the placebo researcher sweeps in and says, I could colonize this particular phenomenon for my own, and maybe it's all nocebo effects. So things like wind turbine, another thing called Havana syndrome. So diplomats that were associated with visited Havana in Cuba. There was if you look this up, and I think you'll see there was sort of, and we opened the book with mentioning this, the idea again, nobody could understand what was the physical substrate of these clusters of conditions. Some people with so-called Havana syndrome, various, as I said, diplomats, people who visited, there was some idea that, they'd fallen illness through some toxicity, or else maybe it was that they had succumbed to, again, some sort of more localized hysterical response, which again is a very negative connotation in saying it, that it was, again, all in their heads. It didn't really exist, and that they'd exaggerated, and as a result of it, they fell ill. I think, again, we've got to be careful, including when it comes to sort of at a public health level. There may well be, we've got to be sort of be intellectually humble here. Scientists need to recognize that it's, particularly in the medical community as well, just because we don't have a current explanation doesn't mean that there's not going to be an explanation. And of course, it is possible that nocebo, these could be manifestations of nocebo effects as well. But I also tend to think that the more ordinary explanation sometimes is the most likely, and it might be we just don't have all the facts. We shouldn't rush to judgment and be too journalistic in our interpretations either.
Mm-hmm. So this is something that I think we've been referring to throughout our conversation, but How does the nocebo effect tie to medical ethics? I mean, what kinds of questions does it raise in the context of medical ethics?
Yeah, it's a great question. So doctors are obliged to be, nowadays they're obliged to be open and honest with patients, and to respect, particularly in the post-war era, Second World War, be open and honest with patients. You've got to be truthful about the state of their diagnosis, but also offering them treatment options, and disclosing to them relevant facts that could inform their decision, furnish them with information they can make a choice, an informed choice. So to that end, the nocebo effect is a sort of slightly disrupting force in healthcare ethics, because doctors also have a duty to first do no harm in the Hippocratic Oath. Sometimes it's inevitable. You can't undergo surgery without an incision, and is there an unnecessary harm as a result of disclosing certain information? So it's a case of what's the trade-off between these two ethical principles. The one is to respect the autonomy of the patient, to be truthful with patients, versus you don't want to cause harm unnecessarily. So that's one source of tension. Another source of tension is potentially for justice in healthcare. So is there an unequal distribution of nocebo effects or placebo effects, which is an interesting question in relation to how people fare in the clinic visit. So some patients may be subject to more unintentional discrimination. Biases may influence. Be very surprising. We know there's a body of literature on some of which is contested for sure, but there are interesting differences in how people experience care, and this systematically shows that, on the basis of your sex, your ageism, race, ethnicity, body weight as well. So how your provider is responding to you, the quality of information they give, the time they give, cues of empathy towards the individual. It would be surprising in a way if some people didn't fare a little bit worse. So there's possibly an issue of justice in the distribution of these effects too, that's been a more overshadowed consideration in healthcare ethics and how it intersects with placebo studies. But that could be another area that's something I've written a little bit about as well. But open question, are some of us doing worse in the clinic visit because of nocebo effects?
Mm-hmm. And which kind of strategies can be adopted by both clinicians and patients to reduce the nocebo effect?
Yeah, so some of it could be that framing of information that we mentioned. Excuse me, so positively framing the information, or following sort of the lead of empirical studies by Alia Crum and her colleagues in positive mindset. So saying, you might experience negative things, but that's a sign that things are going to improve for you. That the medication's working or whatever. Of course, that also induces certain ethical questions too. Is that really ethically honest, or do we need a higher order sort of disclosure about, I'm going to tell you this information that's therefore going to I don't think any provider has time to disclose that level of nuance, but it could be that it's about framing information. The other aspect is taking the time. It's the words that one chooses to use, showing due sensitivity to patients. There's some suggestions among medical ethicists that it's about to reduce nocebo effects could be via something called authorized concealment. So you tell the patient. I think this is sort of psychologically sanitized and a bit unrealistic from a variety of perspectives, telling the patient, there are side effects here. I don't, do you authorize me to tell you that what the side effects are? And the patient can say yes or no. But I think that flags up the information is probably emotionally relevant, and you're more likely to induce the patient to get online and say, what the hell are these side effects that this doctor doesn't want to tell me? So I think that probably would be counterintuitive. But I think there are ways in which you can frame information, present yourself as a provider. Easier said than done, but that these things could be, if we could adopt them a little bit more, that would be beneficial. And then the other thing I should mention here is the use of generative AI is interesting here too, because we're seeing, I've done studies on this too, doctors are increasingly using generative AI chatbots, including commercial chatbots, which they shouldn't be using, such as ChatGPT, to assist them with their documentation. So, and letter writing to patients. So in many countries, you can now get access to your online medical records, which could be another forum for inducing placebo or nocebo effects too. But if your doctor is presenting it using these tools, and one of the top usages for these tools is documentation, according to doctors, those who adopt it. So they may be trying to write their notes more sensitively, and using that as a tool to present information in a way that is framed in a more desirable fashion. And then second to that is patients' use of generative AI, which is a whole separate concern. But there's studies which suggest that generative AI is much more empathetic than doctors in responding in blinded trials, experimental trials. So patients might actually, it's an interesting question, receive more placebo effects from a chatbot than they do from their doctor. That's a whole other question and maybe a whole other hour of discussion. But
Yeah. So one last question then. If, for example, there are doubts about the effectiveness of certain treatments, how should doctors communicate about them to their patients to avoid inducing nocebo effects?
I think doctors should communicate honestly. I mean, that's what they have a duty to do that. If they're uncertain about a treatment, they've got to be honest about that. But a way to frame it may be to say, look, we don't know what the particular effects may be here, but it may be that you could again frame it positively by saying that this might work for you. We're all individuals here. Most of these studies are population-based studies. This might work for you. Give it a go. Let's see how things go. So you could still positively frame the information in a way that the individual leaves the clinic thinking, I'm trying something. They have a more positive effect, more positive attitude that to the extent that these effects are relevant, they could be dialing them down, the negative side effects.
Mm-hmm. Okay, so Charlotte, anything else about the nocebo effect that I might have missed in my questions? Anything else we should know or not?
I think probably the biggest area here, the most exciting area, will be the use of generative AI as it sort of gradually creeps in to both patients' use of these tools to search for health information. So how these tools tend to be extreme. I don't know if you've ever played around with them, but they are consistently very polite no matter what you say, throw at them. And there may be that consistency and the valence of the responses that some of these chatbots can give rapidly and in a conversational way to a patient when they're seeking health information might actually influence nocebo effects, placebo effects, but may also influence when people do seek health from their provider. So we're sort of entering a sphere, I think, of triadic care. You've got the provider, you've got these chatbots that we tend to anthropomorphize and so on. and you as the patient. So I think that intersection will be a very interesting thing, something I'm focused on writing about at the minute. But I think that's an area that future discussions in this field will get into, and indeed how clinicians lean on these tools as well increasingly, whether it is to improve their communication through the kinds of responses that preferable responses to patients, but they're increasingly using these tools. They're not going to go away. So that would be the thing that I think's round the corner, but we don't yet have enough research on. And in general, I should close by saying we just don't have enough research into the nocebo effect, and we do need more replications.
Mm-hmm. Okay, great. So just before we go, where can people find you and your work on the internet? And by the way, would you like to tell us a little bit about your upcoming book?
Yeah, so I'm on Twitter and Blue Sky and LinkedIn at CR Blease, and you can see my publication. I sort of my Uppsala University web pages I don't update enough, but my publications are available on Google Scholar. And yeah, I also have a Substack called Blease on Dr. Bot, where I write about AI, healthcare, ethics, and other considerations. But yeah, I've got a book coming out in September called Dr. Bot, When Human Doctors Fail Us and How AI Can Save Lives, which is somewhat provocative title, but it's really about how human doctors have an enormous task on their hands in modern healthcare, and it's about how sometimes doctors do fail us, even though, I mean, they're working under incredible pressures. But I look at the psychological limitations of doctors on what it is they do, keeping up to date with information and all the rest of it. And I look at how AI may prove to be an important workaround to improving care in the long term. So it's a book that's focused on the psychology of the visit and what AI could do to improve patient outcomes. So it's a very patient-centric book, but possibly a bit provocative as well. But it'll start a conversation, I hope.
Great. We're very much looking forward to it, and I really hope to have you back on the show when it's out. And thank you so much for taking the time to come on the show. It's been really fun and informative to talk with you.
Thank you, Ricardo. I look forward to seeing you again too. Thanks a lot.
Hi guys, thank you for watching this interview until the end. If you liked it, please share it, leave a like and hit the subscription button. This show is brought to you by Enlights, learning and development done differently. Check their website at enlights.com, and also please consider supporting the show on Patreon or PayPal. I would also like to give a huge thank you to my main patrons and PayPal supporters: Per Larsen, Jerry Mullerens, Frederick Sunda, Bernardo Seixas, Olaf Alex, Adam Kessel, Matthew Whittingford, Arno Wolf, Tim Hollis, Eric Alenia, John Connors, Philip Forrest Connolly, Dan Demetri, Robert Windiger, Rui Inácio, Zup, Marco Neves, Colin Holbrook, Phil Kavanagh, Mikkel Stormir, Samuel André, Francis Ford, Tiago Nunes, Fergal Cossen, Hal Herzog, Nuno Machado, Jonathan Labyrinth, João Linhares, Stantantia, Samuel Correia, Eric Hines, Mark Smith, João Eira, Tom Hummel, Sardas France, David Sloan Wilson, Yacila Dez Araújo, Romain Roach, Diego Londonho Correia, Yannick Punter, Dana Rusmani, Charlotte Blease, Nicole Barbaro, Adam Hunt, Pavlo Stasevski, Nelek Bach, Guy Madison, Gary G. Alman, Sam Afzal, Adrian Yeager, Paul Tolentino, João Barbosa, Julian Price, Edward Hall, Edin Bronner, Douglas Fry, Franca Bortolotti, Gabriel Ponce Cortez, Ursula Litsky, Scott, Zachary Fish, Tim Duffy, Sonny Smith, John Wiseman, Daniel Friedman, William Buckner, Paul George Arnaud, Luke Loaki, Georgios Theophanes, Chris Williamson, Peter Wolozin, David Williams, Diogo Costa, Anton Erickson, Charles Murray, Alex Shaw, Maury Martinez, Coralie Chevalier, Bangalore Atheists, Larry Dealey Jr., Old Erringbone, Asteri, Michael Bailey, Dan Sperber, Robert Grassi, Igor N., Jeff McMahon, Jake Zool, Barnabas Radix, Mark Campbell, Thomas Dovner, Luke Nissen, Chris Story, Kimberly Johnson, Benjamin Galbert, Jessica Nowicki, Linda Brandon, Nicholas Carlson, Ismael Benzliman, George Coriatis, Valentin Steinman, Per Crowley, Kate Van Goller, Alexander Hubbard, Liam Dunaway, BR, Masood Ali Mohammadi, Perpendicular, Jonas Hertner, Ursula Goodenough, Gregory Hastings, David Pinsoff, Sean Nelson, Mike Lavigne, and Jos Necht. A special thanks to my producers, Isar Webb, Jim Frank, Lucas Stafiniak, Tom Vanagdam, Bernard Ugni, Curtis Dixon, Benedict Mueller, Thomas Trumbull, Catherine and Patrick Tobin, John Carlo Montenegro, Alnick Ortiz, and Nick Golden, and to my executive producers, Matthew Lavender, Sergio Quadriano, Bogdan Kanivets, and Rosie. Thank you for all.